risks and the adaptation has just been unbelievable. What's been asked of you and the way that the anesthesia department has responded has truly been noticed, appreciated, and we're really awestruck by the work that you've done. The whole peri-operative team needs to be thanked as well. For the last several weeks, our peri-op leadership team and the surgical department chairs, including Peter and Doug Derschel, and Ernst Langell and Kathy Colby, we've been meeting, frequently, almost on a daily basis, and including on the weekends, to try to figure out how to respond to the changing circumstances that we find ourselves in during this pandemic. We were pretty early to the game in terms of suspension of the truly elective cases, and trying to figure out how to adjust the schedules to the types of cases that truly needed to be done, and trying to work our way through that complicated topic, reorganizing all the services, rapidly evolving all of our different peri-operative policies, and doing a lot of this on the fly. We found that this town hall format was a pretty good way of conveying information and some of the reasoning behind these adjustments that we've had to make, and as part of this sort of continuous evolution of our approach. We've got 6 panelists, I believe, if I can count correctly, who are just going to make some brief introductions, commenting about their specific areas and their areas of impact, and how they're thinking about what they've been doing, and then we'll have plenty of time to field all the questions. Again, I thank you all for your willingness to make these unprecedented changes for how we care for our surgical patients, and for all the feedback that you've given to us along the way. Emily Landon from Infection Control is fond of saying that this virus didn't come with a set of instructions, and so we're all learning about it as we go along, and we're all responding to issues, for everything from understanding its behavior and the natural history of the disease, to understanding how we're supposed to respond with PPE and changes in our processes. So we're all learning and adapting every day. So it's been pretty unprecedented, but inspiring to be working alongside this team. So the order of the speakers is first going to ask Ross Milner to make some overall comments about hospital operations and triage in the operating room. Then Vivek Prashand is going to walk us through the approach that we've taken to triaging and prioritizing medically necessary, time-sensitive surgery, and he'll show you that work. Grace Mack will talk about the impact of COVID on coma operations and the adjustments that are happening there. Alan Klock, who's been an amazing partner in this from anesthesia, is going to give us the frontline OR perspective, as well as his thoughts as anesthesiologist. Diane Yamada is going to talk about cancer care during COVID. And then finally, Peter Angelos will update us on some of the discussions that we've been having from around the ethical concerns that the COVID pandemic has given to us. So I'll turn it over first to Ross, and everybody's going to be extremely brief, except me.
Thanks, Jeff. And I just wanted to thank all of the panelists as well, because this came together on relatively short notice, and appreciate everybody's willingness to be part of this. And it's a demonstration, once again, of all the teamwork that's gone on. And I wanted to echo one of Jeff's points. This is unprecedented for us, and the teamwork, collaboration between all of us has been spectacular, and people's patience with a fairly difficult situation has been also amazing. And I just wanted to say thank you to everybody from me, because I receive a lot of the first line emails, but I also just wanted to tell everybody, for all of us feel this way, but it makes us exceptionally proud to be part of an institution like this when we respond the way we do. As Jeff said, we responded pretty quickly. We knew that we wanted to be stewards for the hospital census, for the appropriate utilization and preparation with PPE, and be safe for our patients and be safe for our providers, and really change the operating room schedule very quickly. And many people have commented that other institutions haven't done it this way, and we think we're doing it the right way. The way our triage has worked has really been to focus on surgery that can't wait, and Vivek's going to explain to you a little bit more objective way that we've looked at that. But cardiovascular disease, oncology, injuries that will not heal appropriately if not treated in a certain period of time, and really are focused our effort on that. For those that are not in the surgical department, the way that this has worked is an individual surgeon has deemed the surgery necessary, time sensitive and necessary. That gets vetted through their either section chief or department chair, depending on the departmental structure, and then it gets sent to me and Jeff for final approval. You have to be careful when you look at the schedule. As an example today, not to pick on a specialty, but Dr. Bales has a case that if you just read the case description, you would think is an elective case, but it's actually being done for an infected prosthesis. And so be conscientious when you look at the schedule and know that all of these cases have been really vetted very carefully. The other part that I just wanted to let you know is, as Jeff mentioned, the executive committee is meeting daily. I also attend the daily hospital incident command center calls and know very quickly what the hospital census looks like, what our ICU status looks like, and we're able to make changes with the operating room schedule on a very short notice. But once again, thank you very much, everybody, for your willingness to be patient and understanding in fairly challenging times. And just from my perspective, to let you know that truly all of the small amount of casework that's getting done has been thoroughly vetted, and it's really, truly surgery that needs to get done for these patients' best outcomes. Thank you very much.
Great. Now we're going to ask Vivek, as Prashant does, Chief of Surgical Quality, has really done a credible amount of work to try to put some structure and rigor behind the way we've been prioritizing medically necessary, time-sensitive procedures. And as we try to compare what is the prioritization of an orthopedic case versus a GYN case versus a cardiac case versus anything else, we tried to come up with some way that we could cut across all of these different disciplines and try to figure out how we would allocate the scarce resources of an OR and deal with the medical appropriateness in, again, the unprecedented times. So Vivek will share with us some of that work. Go ahead, Vivek.
Well, thank you very much, Jeff. And I want to thank everyone for really the degree of cooperation that we've all had in these circumstances. And I really want to thank the anesthesia team. Obviously, you truly are at the front lines. And, you know, I haven't had a chance to directly speak and explain sort of the process that we've gone through. And so this is really kind of to provide you with that perspective. And so hopefully, you'll have a little bit more of a sense of how these decisions are being made. And I also want to say, I miss you guys. It's very hard to not be operating for 2.5 weeks. So we were early to the game. We stopped doing non-urgent operations before the American College of Surgeons and other national organizations had recommended it. But at the same time, we have to keep in mind that the word elective is not the same as optional. And there are patients that need surgical treatment for their disease. Certainly, we're re-examining the non-operative treatments that are available and really paying careful attention to time sensitivity with regards to how long we can postpone or delay procedures. But I think that the real challenge in the COVID environment is that the decision-making requires incorporation of factors that we just are not used to thinking about as surgeons. You know, certainly the dynamic resource limitations and the risk of infection to the entire surgical team, as well as to the patient who's violating the shelter-in-place directives that are meant to protect them. And then, you know, we've even in our own institution had the unfortunate experience of having patients who were asymptomatic, who had COVID infection, have acute postoperative respiratory failure. And this is a phenomenon that's been described in other institutions as well. We had a colleague from Madrid who spoke at our leadership meeting a couple of days ago, and they described a similar phenomenon. So we looked through and identified 21 different factors that either increased the risk of COVID-19 to providers, increased resource utilization, or increased risk to the patients as well, and kind of categorized them in 3 broad groups. And really wanted to create a tool that allowed us to integrate these different factors and facilitate the decision-making and triage for these medically necessary time-sensitive procedures. And we've really tried to go away from using the word elective for the reasons I mentioned earlier. So our anesthesia colleagues may not have seen these particular worksheets, so that's why I'm opting to show these on the screen. But basically what we've done with each of these factors is create a 5-point scale with the higher score for each factor being associated with a poorer outcome, increased risk to providers, and increased hospital resource utilization during the pandemic. So certainly the length of the case, the length of the stay that's anticipated afterwards, the need for ICU stay, and you can see that for ICU stay, it's heavily weighted towards even a relatively modest possibility of ICU being assigned a higher score value. Bleeding risk in the context of low blood availability, given the donation center closures, the likelihood and need for intubation, and again, this is really to keep in mind the risk to anesthesiologists and the OR team with regards to the increased risk associated with intubation and the aerosolization. And finally, surgical site, not only with the risk of aerosolization, but with the potential impact on postoperative respiratory function. In addition, we really took a look at the disease process, and I mentioned earlier, examination of both the effectiveness of non-operative treatment as well as how much resources are used or what is the exposure risk of these non-operative treatments. So on this scoring system, a higher score represents less harm to the patient if non-operative treatment is pursued or surgical treatment is delayed, with the concept being that when there's limited resources, those resources are better deployed when non-operative care is either less infection or not even available. And similarly, those limited resources are better deployed where delayed treatment either worsens the outcome or makes the surgery more difficult to perform and hence increases surgical risk. And in order to try to get a sense of the time sensitivity of this decision, we arbitrarily chose 2 time points, 2 weeks and 6 weeks, and made an assessment as to, at that 2-week time point, would the disease outcome be affected, and would the degree of difficulty of the surgery be affected, and similarly with the 6-week outcome. And so that gives a sense of the cadence of the natural history of the disease and allows us to integrate that into the decision-making involved. So adding up those scores for this particular set of factors, it's anywhere from 6 to 30. And finally, the patient factors, which I think this is what probably is most known about the COVID-19 disease as far as the risk of poor outcomes. And so things like age, lung disease, presence of sleep apnea, not only in terms of postoperative respiratory potential compromise, but the aerosolization associated with positive pressure, ventilation with masks, diabetes, and then also incorporating the risk of the patient having COVID-19 in the absence of robust preoperative testing. So again, we've incorporated those factors as well. The higher the factor, the poorer the outcome, the increased risk to providers or increased resource utilization. So how does this all come together? So if you add up these 3 scores, it gives a range between 25 and 105. And so given the fact that we have to reserve OR capacity to address the emergent and urgent cases that occur, what we can do on a day-to-day basis is set a threshold, whereas if the score exceeds a certain threshold, the worse outcomes, the excessive risk, and the resource utilization probably do not allow that procedure to be performed in a justifiable fashion. But by the same token, if the score is lower, that situation allows a reasonably favorable risk and personnel, and so it might be reasonable to proceed. Now, to get a sense of the proof of concept, we came up with the scoring system, and then we retrospectively reviewed a number of cases that have been done in the week of March 20th. And you can see here the green bars represent the cases that were performed, and the red bars represent the cases that were deferred. And you could see as a proof of concept, this scoring system seems to have worked and was in alignment with the ad hoc decision-making that was taking place previously. So I think that this is a transparent process. It's flexible, and it really is a forcing function to really force surgeons to think about these things that they may not normally think about when it comes to surgical decision making. Having that 5-point scale allows some nuance, and doing this really allows us to apply this thought process not only within a particular specialty, but across surgical specialties, and really think of it globally as far as institutional operating room resources. It takes away some of that ad hoc, intense emotional and ethical workload from Dr. Matthews and Dr. Milner and other chairs and leaders with regards to the decision to proceed or not. And I think that it really allows that cadence determination. There's obvious weaknesses to this process as well. You know, statistically, within a particular factor, things might not match up perfectly, and it's inevitable that the weighting of the different factors is going to be inaccurate in the absence of significant data. But it's a good place to start. And I'm encouraged by the wide adoption really across specialties, even without being able to provide a formal presentation the way that I'm doing to the group today. So thank you very much.
Thanks, Vivek. If you, hopefully, I don't know if all the participants are able to see and access the Q&A function, but you can start to submit your questions using that. And hopefully they'll start to pop up on the screen there, and maybe some of the panelists, Ori says he can only see his questions. We'll try to figure out a way to get those up there so that perhaps speakers can do this in real time. All right, my screen just sort of froze out, so I forgot who was the next speaker. Was it Grace? I think Grace
so.
Going to, yes, we will send out those slides. Grace Mack is head of the Comer OR from the operational standpoint, and she's going to talk about how Comer has adjusted. Go ahead, Grace.
Thanks. Good morning, everyone. I would also like to echo everyone else's previous comments and thank the entire teams. I think everyone has been extraordinary during obviously very unprecedented times. Particularly, I'd like to thank the Comer team, obviously the pediatric anesthesia, our entire operating room team, and also particularly the pediatric hospitalists, the intensive care units, as they've also been instrumental, as I'll talk about in a second. As you guys all know, children are not nearly as severely affected as adults by COVID-19. However, working within the same confines of limited resources and everything, we too have also gone down to a limited operating room capacity. And so we have a room that is for add-on cases, urgent and emergent cases, as well as the same medically necessary time-sensitive cases that Dr. Prashant reviewed. Myself and Dr. Mark Slidell are actually working with Dr. Prashant to modify his criteria to make it more PED specific. And so look out for that. We'll be coming out with that so that we can also use the same criteria for pediatrics to help us prioritize our cases. We also have a room available for trauma cases, as the Pediatric Level 1 Trauma Center also remains open throughout the pandemic. We also outfitted our Comer Room 1 with a negative pressure anti-room, which basically acts as a negative pressure room so that we can safely perform surgeries on COVID suspected and COVID positive children. We have also been able to use this for pregnant women so that those in labor and delivery are able to also use the same room. And I think this has been a great resource for our patients, as they have been able to stay in Comer and in one building rather than traveling through the tunnels over to the CCD. Our recovery room is also going to be utilized, a very small portion of it, for the neonatal intensive care unit surge. The American Academy of Pediatrics recently had recommendations that any baby that was born to a COVID positive mother should be in an isolation room. And so this will be where those babies are housed, as well as babies that are under investigation or PUI. And then also our pediatric intensive care units, as well as our 5th floor and 6th floor, are all poised to be able to take some of the young adults from the adult hospital, both on the medical side and the surgical side, to help with the expected COVID surge. And so if you guys ever have any questions or problems over in Comer, please let me know. If I don't know the answer, I'll try to find someone who can help you. Thank you.
Thanks so much, Grace. Next, Alan Clark is going to give us the perspective from the front lines. Alan.
Great. Good morning, everybody. There are so many things to go around, but one thing I think we should all recognize is that the hospital leadership has really been extraordinary. They activated the hospital incident command system in January, and I think we're way ahead of the curve, and activated supply chain pharmacy to start to amass and stockpile necessary supplies and drugs. And those of us who've talked to our colleagues at other hospitals, especially along the coast, we are much better prepared. I also want to give a shout out to John Brickman and the Peri-Operative Leadership Team, who've really been extraordinary. Our people in supply chain and my DACC and surgical colleagues, especially those in the COVID unit. Really it's yeoman's work, and good job, everybody. I think many of you are aware that we did have a patient that was low risk and thought to be COVID negative on March 20th that came to the operating room and decompensated the next day and was found to be COVID positive. And that placed a large number of people on quarantine afterwards. After that date, we decided to treat all airway events, all intubations and extubations as high-risk events, and having the anesthesia providers don and doff appropriate PPE and give the opportunity for the other people in the operating room to step out for 10 minutes after the intubation or extubation. So this obviously has, changed the cadence of the operating room somewhat, but we really feel it's the safest approach. And we'll have to develop, workflows and adapt as we go forward. We've been working on developing an aerosol boxes to be used during airway management and the boxes have been modified to attach to the Neptune smoke evacuation system, which is a double HEPA filtered system, and that should really reduce the aerosol load in the operating room. I worked with Jay Pinto yesterday to make modifications to the box for tracheostomies and other ENT surgery. And we actually are going to do a study to look at, he has a way of measuring the viral load in the operating room or patient room environment to see if the boxes make a substantial difference. We're also, appropriately trying to, I want to give a shout out to Vivek and the MeNTS system for medically necessary time-sensitive surgery. Because I think this really gives a very objective framework to determine which patients should have highest priority. And I know there is some anxiety amongst my colleagues about treating some patients that are high risk, but I really think that every case we've done has been appropriate. Those are really my main updates from the operating room, and we'll hear from a couple more panelists and then have Q&A afterwards. So thank you, everybody.
Great, thanks so much, Alan. There's a question about plans for surgical patients to be tested prior to surgery. We'll update that. We'll come back around to that question at the end. Ross can update us on some of the emerging thinking about that. I think that situation may start to change over the next 24, 48 hours for us. So next up is Diane Yamada from GYN Oncology, who's going to talk to us about the challenges of cancer care during COVID.
Great. Thanks, Jeff. I will just add my thanks to everybody in Peri-Operative Services. I think Ross, Jeff, you've done a fantastic job. Vivek, coming up with this framework for how we think about doing these surgeries. And I have to say that, walking into the operating room and doing a surgery and stepping out during the intubation and watching the anesthesiologist through the window doing the intubation is really a humbling process to watch. So I really appreciate everything that is being done to keep everybody as safe as possible. Certainly that the patient that Alan referred to, who passed away and did not do well and was found out to be COVID positive, was a wake-up call, I think, for all of us who are involved with cancer and cancer surgery. That patient did have cancer. Just to put it within a framework, in Illinois, there are about 72,000 cases of cancer that will be diagnosed in 2020, and the majority of those are breast, lung, colon, and prostate cancer. But for the gynecologic cancers, uterine cancer, ovarian cancer, they contribute to about 10% of all female-related cancer deaths. So we're not talking about a small number of patients here. And in particular, the intersection happens around, the negative prognostic factors for how patients do with COVID are also intersect with the negative prognostic factors and some of the risk factors for development of cancer. So age, diabetes, obesity contributes to a lot of the cancer patients that we find. And then certainly the medications that we use, the chemotherapy agents, some of the immunotherapy agents are associated with an immunosuppressive state that intersects also with negative outcomes for COVID patients. So in addition, just in the past week, for instance, there's been data that's come out of China from Wuhan from 3 different hospitals showing increased cancer mortality or increased mortality amongst cancer patients who are known to be COVID positive. So in China recently, with a small number of patients, about 28% of those patients ended up dying if they had cancer and were known to be COVID positive. And there was a 4-fold increased risk of negative outcomes for those patients that have had treatment lately. So, many of these patients have had chemotherapy treatment or some sort of treatment within a couple of weeks or so of being admitted to the hospital. So it makes us really think about the timing of a number of different things: surgery, chemotherapy, use of immunotherapy, and our use of clinical trials. So that's the framework in which I think of, the cancer and the COVID pandemic. So I think Vivek nicely framed out the use of the MeNTS system. I think that's really given us a fantastic way to think about all the different parameters that go into the decision-making about when we put forth a patient for a cancer surgery. It has forced us to think about utilizing chemotherapy for a longer period of time before bringing a patient to the operating room, for instance, for an interval debulking surgery. That's led to some difficult conversations. But we have to think about those surgical outcomes carefully. From a chemotherapy standpoint, I think we think very carefully about the regimens that we use. ASCO's come out with guidelines about this. Our own Society for GYN Oncology has come out with guidelines for this, perhaps using different chemotherapy regimens that are not so intensive for coming to the hospital or to an outpatient chemotherapy suite, using less neutropenic chemotherapy regimens, using liberal use of growth factors, for instance. Those are all ways that we can mitigate those risks. Using hormonal therapy, for instance, or oral chemotherapy agents or other options. From an immunotherapy standpoint, which has been one of the most promising areas recently in cancer care, with the use of checkpoint inhibitors, for instance, 5% or so of patients will develop pneumonitis. And that obviously creates issues and problems in terms of dissecting out whether the symptoms associated with pneumonitis are related to the checkpoint inhibitor or potentially to COVID. And so, we've thought very carefully about the use of immunotherapy agents for this patient population and really recommended using it only in situations where there's going to be significant and definite benefit. And then lastly, in terms of clinical trials, I think, the COVID pandemic has created a lot of issues for clinical trials. Many of the clinical trials have been not launched. Some have been shut down because of the risk to the patient in terms of exposure, coming to the hospital, the risk of toxicity of some of the trial agents, and certainly things where there are a lot of blood draws, biopsies, things like that, that may portend for more exposure to hospital staff. So I think it's certainly had an impact on cancer care, but I think that we will definitely get through this. We'll come out on the other end and start to launch again. So thank you very much.
Thanks so much, Diane. We're learning so much, as we go on in taking care of these patients and figuring out how to make these decisions. One of the things that is always there in the back of our minds is opportunities to broadcast our experience to a larger audience by writing up some of these things. And sometimes, many of the issues that you brought up is probably something that could be shared with a broader audience. I neglected to mention that the work that Vivek and our team has done on defining the MeNTS procedures was written up for a fast track manuscript for the Journal of the American College of Surgeons and was just accepted yesterday. So that'll be, published online within the next couple of days for other groups to share. So some of the impact on cancer care and the reasoning, particularly for the GYN cancers, there's so much that goes into the thought process, suspension of trials, the issues of immunosuppression, treatment versus not treatment. It's a real opportunity for our teams to share our insights with a broader audience. And that leads us to Peter Angelos, who heads our ethics and wellness program in the Department of Surgery and the ethics program at the surgical ethics program at the McLean Center. And he has given us a great framework to have these conversations in surgery and how to get some of these projects started and thinking about it. And perhaps he'll share some of that in his comments. Peter.
Thanks, Jeff. Thanks for letting me be part of this panel. It's been quite an unusual several weeks. As someone interested in ethics, I've never had so many people want to talk to me, so it's kind of gratifying on that sense. But clearly, we're in a very, very different situation than I think we've ever been in, and especially for surgeons and anesthesiologists, we very much have focused on individual patients, and now we're really having to change our underlying ethical basis for how we practice. And we've had to move from this really patient-centered ethics to a public health ethics. And this is different. I think that this is something that most of us are not used to. And undoubtedly, all of the decision-making associated with what operation to do and what operation to put off is associated with this shift. It's not just what's best for my individual patient, but really what's best for the public health and how we utilize scarce resources. I think it's also important to note that there is significant moral distress that's associated with this change. And really, I think, we see this in the public. I think that we see the level of discussion of ethical issues in the media has increased dramatically. And I do think that we ought not underestimate the impact of this moral distress on us as well as on the public. There is data from Singapore and other places after the SARS outbreak, in a few years ago, there were in the range of 20% of medical staff and nurses suffered from depression and anxiety. So I do think this is something that we have to be cognizant of and will likely impact us in the future. The last thing that I just want to mention is really in an attempt to mitigate the moral distress associated with having to make truly tragic choices about scarce resources. We've done a number of things here at the University of Chicago to try to make that easier on the individual care teams. And so right now, we are not in a situation where we don't have enough ICU beds or we don't have enough ventilators. But there's a lot of planning that's gone into what happens if we get there. And the goal is to take the decision-making about, for example, who gets a ventilator out of the hands of the bedside care team. And those decisions will be made by triage teams. Triage teams are made up of 3 people, 2 physicians and a nurse, administrator, or social worker. They are largely based on SOFA scores. Every decision by a triage team will be reviewed by an oversight committee. And it's really designed to make the process as objective as possible and to take it, again, out of the hands of the bedside care team so that they are not making the decisions to, decide whether to treat or not to treat. So I'm certainly happy to, answer any additional questions, but thanks for letting me say a few words.
Thanks, Peter. We're starting to get questions submitted now, so we can start to dole these out. There are two questions around testing of surgical patients. One is, are there plans for surgical patients to be tested prior to surgery? And the second is, what's the estimated false negative rate for the tests that we're using? Ross, you want to handle that?
Yes, thank you for both the questions. And actually, it's very timely, as Jeff said, because there will be a change to this practice over the next 24 to 48 hours. The testing, unfortunately, is not perfect, and it only is about 70% accurate, meaning you're going to miss about a third of the patients, especially just with one test. But the way that we have thought about this for now, the patients under investigation that are in the hospital, it's not going to change in terms of their paradigm. They will still have 2 tests in order to be cleared. For our MeNTS patients that we consider to be the higher risk, that we think there would be a value of knowing their COVID status, our recommendation is going to be to have those patients come to the curbside testing the day before, so that we know their status when they come to the operating room, and we don't have to wait. Even with the rapid PCR test, it's still about a 3-hour wait to get that result. So this is still a little bit in planning, but it looks like people will come the day before. We'll be able to know their status ahead of time and be able to proceed with their operation if they're negative. And if they do turn out to be positive, that way things can be rearranged and we don't have a patient sitting there in an operating room that's sitting fallow as well. So this will be hopefully communicated out to everybody within the next 24 hours or so, but there will be now a plan in place to allow options for preoperative testing to look for some of our higher risk patients.
There's a question about whether the pre-op and PACU area are going to be used to host patients. And the concern is that from a hygiene standpoint, not private bathrooms or accommodations, only one bathroom available in the pre-op area. Actually, I don't know, Ross, whether you're able to handle that one, or Alan, or it would be good to have John Brickman on, but
I actually can answer that. So right now, the 6th floor space is being designed as a surge space for ICU with approximately 5 beds right now. And as you mentioned, or Peter just mentioned, Peter mentioned this, we're okay right now on non-COVID ICU space, but it is getting a little bit capacity-wise tight, and we may need to have this surge space available. So patients that come to this area will be just ICU level care and will be dedicated for that area. So I think in terms of the hygiene and whatnot that's necessary, we won't have to worry about patient bathrooms. It's not really relevant for these patients. And from providers, there's the hand hygiene that's available. But this will be a surge space for ICU is the intention.
Peter, there's a question for you from Dr. Lengel, who's concerned that it's problematic to interfere with bedside care and when and who to intubate. In cancer, they make everyday decisions when to operate on a patient with multiple medical problems without a committee. Frontline physicians need to be free in their decision making.
Yeah, I completely agree with you. And the idea is that the frontline care team will actually make the decisions that are appropriate for that patient. And so if the patient needs to be intubated, they'll be intubated. If we get to a situation where there is an absolute shortage of ventilators, for example, then, after a patient's intubated, the decision about, who will be placed on a ventilator will then be based on the SOFA scores. And so, it's really not, the goal is not to interrupt the decisions that are made minute to minute by the care team, but rather to provide an objective assessment of the likelihood of survival to make those decisions down the road. And so, it is uncomfortable, I think, as physicians to have anybody telling us what we can and can't do for our patients. But if we get to that situation, and this is truly the doomsday scenario where we just don't have the ICU beds or ventilators, then, these tragic choices will have to be made. And we believe it's better to be made by triage teams than by the care teams at the bedside.
there's a question about how trauma patients will be tested. This is obviously an evolving area, and I guess the answer to that is we don't know yet. Obviously, they're being cared for, and if they go to the operating room, they're being treated as to assume that they are COVID infected. But whether there's going to be a opportunity for testing for them, I don't know. Ross, you want to?
Sure. I think for someone who presents as an acutely injured person who's getting care in the trauma bay, there's really not going to be a value of testing that patient. The assumption is, Dr. Matthews said, is that person is positive. The trauma team and all of the other people caring for that patient have the appropriate PPE as if it was a positive patient. And if they need to go to the operating room, I think it's being handled in the same way. But Dr. Klock hopefully can comment on that more effectively than I can. But there won't really be a value in quote unquote preoperatively testing them because the time frame isn't there to do that. If there is a concern postoperatively, then it would be handled just like any other patient under investigation. But preoperatively, there's no value. But Alan, if you don't mind commenting on the way that the operating room teams and your colleagues have been handling all of our trauma patients would be great.
Sure. Looks like my internet connection isn't stable, so I hope everybody can hear me okay. Yeah, clearly for the Class A trauma patients, it's not practical to have that. For the Class A trauma patients, for the Class A trauma patients, it's not practical to have everybody step out of the room. The surgical team should have N95 masks on and have a procedural mask covering the N95 to reduce soilage of that. And we are treating taking all the precautions that we can and treating the patients if they're COVID positive. I would hope that they are being tested as part of their admission panel so that we have an answer very quickly as to whether they are positive or not. But as Ross said, the false negative rate is significant enough that I still think it makes sense to treat everyone as if they are positive, even with one negative test result.
We're asked, has the number of trauma patients decreased since mid-March? And the answer to that, sadly, is no. I think there were something like 17 trauma patients just yesterday with the warm weather. So the volume has maintained. There may have been a shift in some of the types of injuries that are seen. Unfortunately, more domestic violence. I haven't seen the total tally and the spread of the numbers. Alan, you were raising your hand. Did you want to comment on that or no? There's a question on do you see that question, Ross, about indicators on the patient chart to help with smoother or consistent communication about COVID status?
I do. You know, one of the interesting things, every time we have any of these Zoom meetings, town halls, any of these discussions, every time I think I know a fair bit of what's going on in the hospital, there's always a question that proves to me that I still have something to learn. And the answer is, I don't know, but I will find out. I know that there is a specific note that's put in the chart by the infection control team when a patient is cleared. And honestly, I think anybody who is COVID positive is being transferred to one of the dedicated units once they've had a positive test. The patients under investigation will say that, and then there should be a note that's clearing. I don't know how that's looked at Epic, and I will find out and try to get a note circulated to people because I don't know what that looks like. I don't know if somebody else on the panel knows, but I actually don't.
Okay, there's a comment from Dr. Gottlieb. Perhaps we should intubate Class A trauma patients in the ED prior to transport. Alan, do you want to take that question?
Sure. I think that we need to do what's best for the patient, and in many respects, the trauma bay is, I'd say, even more risky for other healthcare workers, and often there are other patients in the trauma bay that don't have PPE on. So, I think that the risk of the overall risk may be actually lower to intubate the patient in the operating room than in the trauma bay.
Great, thank you. We have no more open questions. If there's anybody else who wants to submit a question, now would be the time to do it, and otherwise we can wrap up.
Yeah. Jeff, somebody has their hand up, although
We
I
have a
don't
hand
know.
up.
I don't know how.
we-
So what? How does that work?
I'll do loud to talk here. Andrea.
If you unmute yourself, Andrea, I think you can ask your question.
Oh, come on. Sorry, that was a mistake.
Okay,
Okay, sorry.
no problem. If there aren't any other questions, I'll just like to wrap up again and thank our entire peri-operative team. You know, John Brickman and Renee have just done an absolute amazing job in coordinating this day-to-day and working with the faculty leadership. My partners in the other surgical departments and anesthesia have just been extraordinary, and working alongside them every day has really been incredible. There's a request for an update on the MTP, revised protocol for the use of MTP components. We'll try to get that out to you. That's easy to do. And any other questions can certainly be submitted afterwards. You can just email any of us directly, and we'll try to get that information out to the group. Hopefully this was an effective format to answer some of your questions and to get some information out to you. And we'll sign off now. Everybody have a great rest of the day, and keep safe. We'll do this again.